Please silence your phone. If the secretary would please call the roll.
Senator Deneen, Senator Funky Fromeyer, Senator Girdler, Senator Herron, Senator Mays Bledsoe, Senator Meredith, Senator Mills,
Here.
Senator Webb, Senator Williams, Representative Bojanowski,
Here.
Representative Callaway,
Present.
Representative Kleins,
Here.
Representative Dietz, here. Representative Doan, Representative Duvall,
Here.
Representative Elliott, Representative Holloway,
Here.
Representative Mosier, Representative Pollock,
Here.
Representative Rayburn, Representative Riley, Representative Rorks,
Here.
Representative Stalker,
Present.
Representative Wilson, Co-Chair Heverin, Chairman Carroll.
Here. We do have a quorum and are duly authorized to conduct business. A couple new staff members would like to welcome today Cameron Franey, who is an analyst. Cameron, welcome. And Sarah Walco, who is a graduate fellow from the University of Louisville. Where's she?
She's right.
Where? Oh. Welcome to both of you. We're going to go a little bit off the agenda today. We're going to start with the hearing on the 2025 Preventive Health and Health Services Block Grant. And folks, I would ask that you please expedite this as much as you can. We have a lot to cover today. I do want to thank you for being here, and I will turn the floor over to you. Please introduce yourselves for the record.
Thank you. I'm Julie Brooks. I'm the Policy Specialist for the Department for Public Health.
I'm Elizabeth Good. I'm the Director of the Division of Prevention and Quality Improvement for the Department for Public Health.
And good afternoon. I'm Andy Waters. I'm the Assistant Division Director for Maternal and Child Health in the Department for Public Health.
Sometimes they change people. So that's good.
Okay, I'm going to be speaking with you very briefly about the Public Health Services Block Grant, which provides about $2.3 million annually to Kentucky. Funding is granted to 61 states and territories, and it's based on a formula, so it's not a competitive federal grant. With a small amount of money, we're able to fund a number of really important programs to public health in Kentucky. They include the Office of Performance Improvement and Accreditation, many grants to local health departments called Community Health Action Teams, the Kentucky Office of Community Health Workers, the Kentucky Prescription Assistance Program, the Kentucky Asthma Management Program, the COPD program, Education and Workforce Development, which is online training, and lastly, the Sex Offense Set-Aside, which is a requirement of the federal funding, and that goes to the Kentucky Association of Sexual Assault Programs. Are there any questions about the Public Health Services Block Grant?
Seeing none, please continue.
I'm here to talk about the Title V Maternal and Child Health Block Grant. That is a block grant that was authorized in 1936 from the Social Security Act, and it's currently existed in its form as a block grant since the 80s. It's $11.7 million. Of that block grant, 35% goes to address children and youth with special health care needs through the Office of Children with Special Health Care Needs. The remaining 65% is addressing maternal and child health populations, including infants, children 1 to 21, and pregnant women. The vast majority of that funding goes out to the local health departments to support the communities and those populations living in those communities. And when I say that, that's about 80 to 85% of that funding goes to the local health departments. Very little is maintained up at the state level other than a little bit for personnel and some statewide projects. It is addressed through a needs assessment every 5 years where we relook at data to address what we need to in the populations. And that's a needs assessment that's conducted with community members, providers who provide services, healthcare, social work, any other type of services to those populations, the local health departments, and including the residents. They all provide insight into where we should address that money for about 5 years at a time. Are there any questions about the Title V block grant?
Yeah, well, that was quick. Any questions on either? Okay, I'll entertain a motion to approve the 2025 Preventive Health and Health Services Block Grant and the Maternal and Child Health Title V Block Grant. Have a motion? We have a motion and a second. Who was the second? Representative Mosier. Okay. Secretary, please call the roll.
Senator Deneen. Senator Funky Fromeyer. Senator Girdler. Senator Herron. Senator Mays Bledsoe. Senator Meredith. Senator Mills.
Aye.
Senator Webb. Senator Williams.
Aye.
Representative Bojanowski.
Yes.
Representative Callaway.
Aye.
Representative Kleins.
Yes.
Representative Dietz. Representative Doan. Representative Duvall.
Yes.
Representative Elliott. Representative Holloway. Representative
Yes.
Mosier. Representative Pollock.
Yes.
Representative Rayburn. Representative Riley. Representative Rourke.
Yes.
Representative Stalker.
Yes.
Representative Wilson. Co-Chair Heverin. Chairman Carroll.
Aye. Do we have anyone that needs to record a vote? Okay, on a count of 19-0, motion is approved, and the two block grants have been approved. Thank you for being here today, and thank you for expediting. Okay, the next item on the agenda will be the Community Health Lives Development Grant, or Development Waiver, I'm sorry, the Child Waiver. And I would ask Commissioner Dennis, if you would, and the staff that you have with you, please come to the table. Before we do that, we need to get the minutes approved. You all have those in your packet. Could I have a motion?
So moved.
Have a motion? Have a second?
Second.
All those in favor, please signify by saying aye. Aye. Opposed, no. Minutes are approved. In 2024, on House Bill 6, the House proposed a child waiver to the legislature, which did pass. This is the language from that waiver. Included in the above appropriation is $4,201,900 in general fund and $10,541,600 in federal funds in the fiscal years 25 and 26 to develop an HCBS Section 1915C waiver for children ages 0 to 21 with severe emotional disabilities, autism spectrum disorder, and intellectual disabilities and related conditions. Notwithstanding 45-229, any portion of the general fund not to expended for these purposes shall lapse to the Budget Reserve Trust Fund account. Mandated reports shall be submitted pursuant to Part 324 of this Act. This particular waiver is, my understanding, open for comments now. There have been a lot of discussions that the waiver that has been formulated and is being proposed is not what the legislature asked for. And it's not that the waiver that is proposed would not serve a population that is in need of those services at all, but there is a lot of concern that it was not the intent of the legislature for the waiver that resulted. It was meant to serve children who were basically on the Michelle P. SCL waiver, and to remove those kids to a child waiver to free up waiver slots for adults. And so I asked the cabinet to come here today. And again, this is a difficult conversation because there is a population that's going to be added into waiver services that it's needed. So this will be a tough conversation to have. It'll be a balance between what the legislature expected and what happened. and what the results of that are. So that's kind of the foundation of where we are today. And Commissioner Dennis, thank you and your staff for being here. And I would ask you please introduce yourselves for the record, and you have the floor.
Good afternoon. My name is Lisa Dennis, and I'm the commissioner with DCBS, and I am here with my counterparts from Behavioral Health and Medicaid.
Katie Marks, Commissioner for the Department for Behavioral Health, Developmental and Intellectual Disabilities.
Leslie Hoffman, Deputy Commissioner for the Department of Medicaid Services. First of all, Chair Carol, and other members of the committee, we'd like to thank you for the opportunity to come speak to you today about this opportunity, and we would like to share our Kentucky 1915C Child, CHILD, Community Health for Improved Lives and Development Waiver. We feel like this targeted population waiver is a game-changer initiative to support children with complex emotional, behavioral, developmental needs, and to keep Kentucky families intact and minimize the need for institutional care. First of all, what is the 1915C Child Waiver? The Child Waiver is a new Kentucky Medicaid program designed for Kentucky children and youth with significant behavioral health or developmental challenges, services that they need while they're trying to stay in home and in school in their own home and in their own community. Our anticipated date right now is January of 2026 for implementation. Who are we trying to serve? We're trying to serve those children and youth that are in the most complex of need, the very acute of the acute children. We are focusing on children and youth that are stepping out of acute psychiatric inpatient care, such as a PRTF, or an at-risk out-of-home placement due to requiring intensive behavioral health and residential supports. These are also children that, for the child's waiver, that we are including services like clinical therapeutic services that are designed to foster a step-down approach, coming from the highest level of care in order to return those children back to their own home and in their own community. Who the 1915C Child Waiver will help. These are children and youth that are under the age of 21 with significant behavioral health or developmental disability needs, children and youth who need a level of care that's similar to what we would provide in a psychiatric residential treatment facility or a PRTF, an intermediate care facility for individuals with intellectual disabilities, which is an ICF-IID, or a hospital, and because it's an HCBS program, can be safely maintained and supported in their home or in their community with the right services.
So you heard from Deputy Commissioner Hoffman. You heard her describe the waiver and who it is intended to help. In the next few slides, we want to discuss what the trends and challenges are for this population. So we are seeing a growing number of youth with complex behavioral health needs, and their families are experiencing significant barriers to accessing services and supports. The existing system of care lacks the capacity and range to support children and youth with complex needs, which has resulted in delays in discharge from inpatient psychiatric hospitals due to no identified step-down, ongoing incidents of non-traditional placements for youth in out-of-home care, transition challenges for youth stepping down from intensive restrictive treatment settings, and youth coming into care due to conditions related to the child's behavior, not maltreatment. And these challenges have persisted despite significant interagency efforts to increase access to intensive services through different pilots and different initiatives. And here you see what a youth with complex unmet service needs looks like. This is a youth who has had multiple system involvement. They've been involved with the behavioral health system, the child welfare system, the justice system, or the developmental disability services. They have serious health symptomology, so depression, psychosis, substance use disorder, adjustment to trauma, medical complexity. And they also have chronic risk behaviors. They have behaviors that pose an imminent risk of harm to themselves or others, and major functioning impairments impacting their ability to participate in school and other social settings. And they've had prior interventions that have been insufficient. And the protective factors are unlikely to mitigate risk. Their caregivers are doing everything they can to meet their needs, and resulting in a youth with complex unmet needs. And here on this slide, you see that in 2023, there were 60 incidents in which a youth who was in out-of-home care spent 90 consecutive days in an inpatient psychiatric stabilization setting. 60 in 2023. That increased by 6 times in 2024 with 379 children. So we have seen timely step down of youth who have stabilized in an inpatient psychiatric setting is critical to the functioning of our system of care, and the lack of appropriate community-based services to provide immediate intensive supports presents a barrier to placement with family caregivers, including relatives, fictive kin, and foster parents.
Thank you, Commissioner Dennis. Services were selected by a multidisciplinary team and a children's feasibility work group. We looked at peer state comparisons, and we invited and had feedback, thoughtful feedback from advocates, families, provider groups, case managers, and the general public. And from that, we established the following array of services and supports. I won't read this to you in detail, but I do want to highlight what each of the service descriptions are for the key benefit pieces. And so the first is case management. This would be for all youth who participate in the child waiver. So these are activities that include assisting participants in gaining access to all of the waiver services and other needed Medicaid state plan or non-Medicaid funded community-based programs to support comprehensive home and community-based needs. The community living supports is the second, and these are intended to provide direct one-on-one assistance. This can include hands-on assistance, reminders, cueing, observation, training, while both facilitating independence and promoting integration into the community. This is a really vital step that is the kind of the transition between our highest levels of care and being able to be in the community. Environmental and minor home modifications are any necessary adaptations to a private or family residence that would be required to ensure that a child or youth's health, welfare, and safety is ensured. Next slide. Respite, this is important. Respite for caregivers is provided on a short-term basis due to the absence of or need for relief for the primary caregiver. Supervised residential care, another critical benefit to this package, is targeted for youth and children who require 24-hour intensive residential services but do not need to be at that highest level of care and can thrive in a much smaller setting with just a few other youth or on their own. The supports provided in supervised residential care are always individually tailored, and they assist with skills like acquisition and retention, improvement in skills related to living and being in the community. And then clinical therapeutic services, so this is step down and aftercare support, are designed to address that family crisis prevention, right? We're caring for the child, but understanding them in the context of family. And so this is family crisis prevention and stabilization supports for youth who are enrolled in the waiver, the primary caregiver, and the family, and this would include foster care families. And this is approved based on the needs of the child, the needs of the families, to mitigate higher intensity longer-term services that are needed. Thanks. And so if we summarize what this waiver looks like for folks, it is a fixed number of enrollment slots. There is a standardized needs-based assessment that is child-specific to determine the functional eligibility. And so it's not just about needs-based, but doing a functional assessment of needs to understand if the services and supports that are in this waiver match and meet the child's needs. They are Medicaid services that are not otherwise available through the standard benefit package, and all services and supports will be individualized service plans and include care coordination.
The 1915C child waiver, and we've looked at this at a very targeted approach and a targeted population with high acute needs. House Bill 6 allocated $14.7 million for state fiscal year 26 to support the creation of a home and community-based waiver service, HCBS section 1915C child waiver. These funds were designated exclusively for benefit services, and that's what we've used them for. To ensure the most effective use of those funds, we developed a strategic and targeted approach that was implemented by giving priority to the children with the most acute and complex needs, providing fully individualized and comprehensive care stabilizing children most at risk for institutionalization, and minimizing long-term cost and supporting better outcomes in the least restrictive environment possible. I wanted to remind everybody, if you've listened to any of Medicaid and my partners here at the table, any of our presentations recently about Families First, I wanted to remind everybody that the 1915C child waiver is part of Families First. Families First is a comprehensive multi-year initiative aimed at enhancing and existing the system of care for all Kentucky children and youth. And these are things that we've already completed. You will see that we have the SHINE, which is a grant that we have related to children, and it's for enhancing access to the delivery of school-based services for Medicaid and CHIP eligible and enrolled students. We also have Kentucky Cares, and that is a grant that we applied for in conjunction with our Consolidated Appropriations Act, which you may be aware that we're required to come in compliance with Section 5121 of the 2023 Consolidated Appropriations Act for youth that are confined and coming out and re-entering into the community. We also have the CHI Mapping, which stands for Children's Health Initiative, and that is a multidisciplinary group across the cabinet and even outside of the cabinet. And most of these, can I just go back, most of these initiatives we're working with our sister agencies even outside of CHFS, such as DJJ and DOC. The CHI Mapping is used to track and report all of our children's initiatives, and it also gives us the ability, when we're asking for new programs, to leverage what we have and to utilize each other to fill in the gaps for the continuum of care for these children. The funding modernization is currently under evaluation, so we are meeting and working on that, and that is about restructuring of Medicaid payments for medically necessary treatment services. And again, I'm working with my sister agencies that are sitting at this table. The next in this continuum, so everything up to that this point has either been worked on or completed. The next level is the high intensity service need, and that's the 1915C child waiver, and it is designed to meet the child-centric care, supported services, housing, custody, and placement, and other health-related social needs for these children. Very targeted, high acuity, high need children. And also you can see that our plans are for a children's state plan amendment in the future, to plan for a state plan amendment that would also assist with the appropriate resources, housing for children and youth in need of placement and services. The current status right now for the 1915C waiver, Carol, as you mentioned earlier, we have already been through the public comment period. It is available for review, and we provided that link. The public comment actually ended on July the 15th. We are currently going through all the responses and preparing answers to those questions, and that we have we'll have those completed sometime in August. We also plan to submit the waiver plus the questions and the answers from the public comment all to CMS sometime in August, probably later for August. And of course, where can you learn more? We do have a waiver help desk email that you can utilize, as well as a waiver help desk phone number to call. And we also included the child waiver summary if anybody wanted to take a look at that due to the fact that the public comment period is over.
First, I want to apologize to the two of you for referring to you as staff. A question that I have, this population of kids, can you kind of paint a picture of who these kids are and where or how are they being served at this point, and what have been the struggles with this population, and how many kids will this waiver, how many is it estimated to serve?
The waiver is estimated to serve 100. There's 100 slots, right? And the population, this is for, again, children with the most highest need, looking at youth who are currently at risk of or at risk of hospitalization or stepping down from hospitalization, at risk of out-of-home care placement, We're looking at youth who have had 2 or more placements. For example, youth who've had 2 or more foster care placements, or have had a number of engagements with with law enforcement, just the justice system, etc. So it's looking at serving those youth with the most complex needs.
Heard comments about the kids that are sleeping in DCBS offices. Will this, or to what extent will this address those kids?
It could serve some of that population. Yes, Senator Carroll. We at any given time we have probably 3 to 5 youth who would qualify for this waiver that are in need of placement and treatment.
Okay, and what within the cabinet, what was the process to decide to move in this direction? To me, the language in House Bill 6 was fairly clear. And again, these are both populations that I and others advocate for very strongly. But it is clear that this waiver was meant to serve a different population. Talk to me about the process that you all went through, and how did you come to the conclusion to address this?
I'll take that question. We knew that we had to address a high needs population based on what we were working on with our much larger, broader vision of Families First. We knew we had to identify those children that were falling through the gap. The 1915C that was included in the budget, again, was $14.7 million. And so we were trying to figure out what we could be able to complete and support for the $14.7 million. With a 1915C waiver, which is a home and community-based waiver, and I know you have probably heard me say this before, we have to ensure that we spend less than or equal to what we're currently spending on this population with a better quality of life and outcome. So that's kind of where we backed into that 14.7, and we realized that we could address this gap, this need for the high-intensity service delivery with that 14.7. We utilize data from other acute programs that we have here in Kentucky. If you all know that we do have an acute 1915C brain injury waiver, acquired brain injury waiver that is acute, and it is normally a shorter term basis, and it is used for rehab type of purposes, kind of to stabilize the person before they re-enter the community or go live in the community in their own home and with their families again. So I took the numbers kind of from there. I know we were in compliance with that waiver and kind of took a look at what we were spending per member, knowing that this one was going to require a higher pay for residential care. What we ended up establishing in this particular waiver was $523, which is 74.33% higher than any other waiver we have here in the state of Kentucky. So again, it's an HCB waiver, and we were trying to fit a program that was going to be, pretty costly. And we utilized that all for benefits. So I didn't leave much room, I'll be honest with you. I did not leave much room from what we estimated per person. You also, one other caveat that you need to be aware is if a child or an adult is in a waiver, the cost of the member has to be calculated of what they cost in the waiver plus what they would have what we call straight Medicaid. So anytime that you're in the waiver and you go to get your medication, or you're admitted to a hospital, or a doctor's visit, that's not included into the waiver cost. So we have to add the two things together. So it becomes very costly for an HCBS program. So that's how we kind of backed into the numbers and come up with 100 slots per year. So that's any given time for the 5 years. If CMS gives us the authority for this waiver, it's 100 per year. The only reallocation we can make is if somebody passes away. You've probably heard us talk about that before. We're not able to reallocate any slot. It's called unduplication unless the member passes away.
Okay. How many SCL or Michelle P. waiver slots would that amount of money funded? Was it 14?
Just a second. I think currently right now, I don't know if I have hang on just a second.
And that's
I think-
14.7.
I'm looking
million.
at right now. The SCO waiver on average probably is a little bit lower than the ABI acute waiver on an average. And they are different comparisons. Nursing facility with a brain injury component versus an ICF IID. That's like your Oakwoods, your Outwoods, those type of institutional settings. I could calculate that for you. I can't think right offhand. We would have been able, if it were SCO slots, there could have been more. That's correct.
Okay, if you could get a number, because that question comes up a lot during conversations. Representative Stalker, you have a question, ma'am?
Thank you so much, Chair. My question, two folds. One, is 100 slots enough? Go ahead and answer
We
that.
had to base it on what we received in the budget, which was 14.7 million in fiscal year 26 only.
I'm sorry, will you say that number one more time?
14.7
$14.7 million is what was allocated for 100 slots.
for fiscal year 26.
Year 26. Here's why I ask. So I think you said 2 or more placements in foster care, correct? To be eligible for...
That was one potential identifier for this population. It would not have to be, but that would be one potential identifier.
Yeah, there will be a functional needs assessment.
Correct.
It's not based on having been in foster care. Youth that have not been in foster care, if they have meet the criteria, would still be eligible for this. So that was just one example of demonstrating the severity of need.
Sure. The second part to this question is we have about 10,000 kids in the state of Kentucky that are in foster care. And a report that I think Bellwood Brooklawn did indicated that Kentucky children are often 2 or more placements in foster care. And then I believe the Annie E. Casey Foundation indicated in a separate report that it was 3 or more. So I ask that because while I understand that this is what was allocated, the real question that we have to ask ourselves is this going to meet the need? And while there are other requirements that I understand that will be factored into this assessment, that's a pretty alarming number, right? If 31% of 10,000 kids that we know for sure will probably have 2 or more placements, I just feel like that puts us in a position where we're not going to be able to serve enough children. So I guess the way I'd like to end this question to you is, what is the ideal number that you really need? Because that's what we as a body need to be prepared to fund.
I think we'd need to go back and assess this. This should only be for a subset of that population, though. This level of intensity of services, even for those youth maybe that have had 2 or more, this probably is more intense than they need. But that's a question that we could go look through our existing data and come back to you with. Mm-hmm. It's a valid question. We absolutely share the desire to understand exactly what it would take to meet the needs of all youth.
Thank you. And I say this as a former foster parent, and I can tell you I've had a couple of kiddos in my house, one in particular who multiple placements, multiple residential placements that no longer would allow that child to come back. This was a kid that was leveled at the highest level, right, and was put with a home such as myself. So the need is great. I know we definitely have some very challenging kids out there who've had some really horrible things happen to them. So I always tell people, please replace the word behavior with the word trauma, because that child has been through a lot and they're having a very normal reaction to all the horrible things that have happened to them. But I just want to make sure that we're actually meeting the need that exists. Thank you.
Okay, we're going to take one more question. I would ask that Representative Bojanowski please hold your question. We will have more time after some others testify. Representative Rourke.
Thank you, Chair. I just want to say thank you all for your presentation. I think it's undoubtedly a need that we're seeing in our community and in our state to address this population and the highest acuity youth. But I do have a concern, I share with the chairman, that this doesn't really get to the heart of us cutting down our waiver waitlist crisis. We have thousands of folks that are on that wait list waiting for services who can't get it, families who can't go to work because they're taking care of loved ones in these situations. And so I think that was always the spirit of pulling out children into this waiver was to really offset and try to help manage the waiver waitlist crisis. So can you speak more to how this is going to cut down on that waitlist, or is this truly a separate pocket that we're trying to address on this other issue that we're looking at?
I'll take a first stab at this. So I think we're specifically trying to look at a very targeted population as the one that Commissioner Dennis has described right now. We know that the wait lists are difficult right now, and we know that. We know that the wait lists are difficult. But this was to address a very specific population. And again, what was written in the bill, House Bill 6, was a variety of populations, and we based this particular waiver on need, not a specific disability, not specific to ABI, or not specific to SCD, or not specific to DD. And I know I'm talking in acronyms, I'm so sorry. But this was based on need. So this is to develop kind of what Commissioner Mark said. It's a subset of that larger group that we want to work on, and that is part of our Family First vision. I would just mention too that this is just an estimate for me. I don't have everything in front of me, but it would be about 135 slots instead of 100. Now, mind you, I already said I took the highest residential care, which is ABI acute, and gave that a 74.33% increase. It would be even a higher request in the SCO waiver. So I don't know if CMS, it would probably be more than double for the SCO waiver. I don't know if the CMS would agree to that. I can't speak for them. They're our authority.
Yeah, I guess the concern that I have is, of course, this is a different population than the one that we were trying to tackle. So whether it's 135 slots that could have been used to cut down on folks that have been waiting already and that were already in our pipeline that we've already identified, now we're identifying new individuals for services, needed services, but it's just a whole different population. So thank you.
Thank you, Representative. Thank you, Commissioners. And if you all would, please hang around till the end. I'm going to get a little bit out of order right now and ask if Auditor Ball, if you and Ombudsman John Great would please come to the table along with Heather Wagers. Last night when I was preparing for the committee, I ran across a letter that the Ombudsman had written related to this waiver and expressing some of the concerns that you just heard. So late yesterday evening on my drive to Frankfurt, made some calls and asked them to be here, and they graciously agreed to appear. So with that being said, please introduce yourselves for the record, and you have the floor.
Thank you, Mr. Chairman. I'm Allison Ball. I'm the Kentucky State Auditor. To my right, I have the Ombudsman, who is in my office, John Great, and the Deputy Ombudsman, Heather Wagers, to my left. Thank you for the opportunity to discuss this. We get a lot of phone calls in the Ombudsman's office, and sometimes they come through the Auditor's office as well, but primarily to the Ombudsman's office, which is within my office, about waivers. We hear this constantly. In fact, we began hearing this quite a bit earlier this year because there were several individuals who have been removed from HCB waivers, people calling on behalf of their children, and we've done some work trying to get some clarity about that particular issue, but we're acutely aware of how long the waiting lists are at this point in time. And so in our discussions with people who call in, we've talked about the child waiver. The child waiver is coming, and this could be a solution to some of the long wait lists. So when we saw, and this has already been discussed quite a bit already today, but when we saw the proposal that added some restrictive language to the statute that you all passed, that's when we felt like we had to make a comment, given the conversations that we have with members of the public. So I know you know this, but the restrictions, and it's been discussed already, are 4 parts. 1, the child has no stable housing or is in serious risk of losing their housing because of the child's disability. 2, the child is in foster care and has been moved at least twice in the past year due to the child's disability. 3, the child's had at least 5 interactions with law enforcement in the previous year as a result of the child's disability. Or 4, the child will be released from a treatment facility within 45 days and needs support at home offered by the child waiver. So as you've already heard, as is pretty clear, that dramatically changes the language of the statute. So we filed a comment addressing that issue, saying as much, that this would restrict the population that this was intended to help. Just just by way of big picture, there are 725 children between the ages of 0 and 21 who are on an HCB waiting list right now. There are 7,388 children between the ages of 0 and 21 who are on a Michelle P. waiver wait list. So it is a really big population, and this does seem to exclude those families that are waiting to get on there. That's number one. That's our big picture. We did comment on a variety of other things, and I know we're trying to go quick on what you want to hear from us today, but I do want to mention at least one other issue, and that is this proposal would not provide for participant direction of services, stating that only certified Medicaid enrolled providers, not relatives, parents, or foster parents, could provide services under this waiver. And this is directly contrary to what federal guidance has been, and it's directly contrary actually to what focus groups have said. It's very, very, very important that these providers, and it's available in other waivers, that they can be involved in providing services, and that would exclude it, which would be a dramatic change. But it does seem to be a way that it targets this towards children who are already in foster care or perhaps at DJJ, those type of institutions. So we have great concern that those first 100 or 135 kids would not be from the general public, would not be from those wait lists, but would be from other areas of population who need help and services. Totally agree. 100%. But my job as an executive, you all write the law. We want to make sure that we're enforcing the law that you have written, and also ensuring that what you have appropriated goes to what you have intended it to be appropriated for. So we care very deeply about that. If I may, Deputy Ombudsman actually has a child who is in this vulnerable population group, and if you would allow it, a really quick human example of what this is like for these families, it might be beneficial to this body to hear that.
Hello, thank you all. Again, Heather Wagers. So I have a child with profound autism. He was born at the end of 2018, and we started seeing regression at the December mark of 2019. And as many of you know, what happened in 2020 was COVID. At the time, I was fighting to get him diagnosed. I have an older child who also has autism, so I recognized the signs early on in my second child. And trying to get services, first steps wouldn't come to the house because COVID was in place. You know, we were only doing telecommute, phone calls. Only providers were providing services like speech therapy with mask on. Anybody that's tried to teach a child to speak wearing a mask, that's a laughable assertion that is going to be a workable solution. So my child is still nonverbal. He receives over 40 hours of therapy and services year-round. And I just want to highlight that kids like my son, the only way that they are eligible for this child waiver is if my husband and I were to give him to the state as custody. I'm sorry, that's unacceptable. Also, these children who were born during COVID, while there's waivers so much, there's such a long wait list for waivers, and it's a first in, first out, they're not even going to mark the surface of getting eligible services. We know that critical intervention early is so important to this population. There's just a lot of things wrong with this. The General Assembly, I applaud you all for appropriating funds. You all have heard these issues. You all have been listening to families like mine who are desperate to help their children. We love our kids. We know what's best for them. This is not what's best for them. I do sympathize with the target population. They need help. I am not saying that at all. But this additional criteria excludes families like mine. Thank you.
So, Mr. Chairman, that is a summary of why we filed our comment, and those are our points of clarification that we've asked for. There are a few other ones, but they're a little more detailed and specific, but that's the big picture.
Okay. Mr. Ombudsman, do you have any comments?
Well, Chairman, I've got greater luminosity to my left, but as you will recall, I did have 20 years of legislative staffing service. When you pass the budget, it's not a guideline. It is law during the biennium. It starts off with being enacted by the General Assembly of the Commonwealth of Kentucky, and as the chairman noted, you created a waiver program that had two elements, A plus B, an age range and conditions. Now you have a cabinet adding in a third element. That's C. Our concern, as the chair has noted and as the auditor has noted, is that only the legislature may appropriate funds. The executive may only spend funds as they have been appropriated, and we would have great concern as to this program design and adherence to the budget language and the Constitution itself. Thank you, Mr. Chairman.
Okay, I think we're going to move forward. If you all, can you stick around for a little bit, please?
Yes, sir.
Okay, thank you all three for being here. Now I would ask that Jennifer Hall, Michelle Sanborn, and Philip Elliston. And we will have time for questions at the end. I just wanted to make sure that we could get all this information in from the different perspectives. If you all would, please, Michelle, starting with you, please introduce yourselves for the record, and you all will have.
Hello, I'm Michelle Sanborn, President of the Children's Alliance.
Hello, Jennifer Hall, Executive Director of Key Assets Kentucky.
Hello, I'm Philip Ellison. I'm Philip Ellison. I'm a parent advocate.
Okay. And I would ask that you please be concise with your statements. Please do not repeat what we've just heard. We are in a time crunch. Please proceed.
I'm Michelle Sanborn with the Children's Alliance, and we represent 38 providers that provide residential, foster care, behavioral health services for children. And when we were asked to share our thoughts about and the impact of this child waiver, we really wanted to just articulate that we just had a lot of questions. We weren't really sure exactly who we were trying to kind of target and identify to meet the needs, but we did have a lot of questions. There are some positives about it. We're excited that obviously it is focused on high need kids. It is for community care. It is to work to stabilize kids. And it really is for kids in custody or not in custody. Several years ago when they were doing a feasibility study and they had an advisory group working on a child waiver, one of the things that came out several times was the need for behavioral health services in the home. We used to have programs that were in the home and were very active wrapping services around these hard-to-place youth. And one of the things that we've seen is the decline in that. So I asked Department of Medicaid Services to share. These are commonly used codes, behavioral health codes that we provide. And you can see in the last 4 years, these commonly used codes overall are declining, yet the need is increasing. And the reason why these programs are declining in the home is because therapists and services, they cannot afford to be in these communities to provide these services on the reimbursement rate. So we're losing the in-home and therapy services. One of the other things that we heard was about transportation. Again, the need for that in-home services because there were transportation needs. One of the other things we heard back then was the need for therapeutic services in the home. And then we had a question of they're providing that through this clinical therapeutic supports, but they're only allowing licensed independent providers to provide those services when many of our agencies use associate level, which is still a master's level therapist to provide those services. They also are capping the units for this clinical therapeutic services to 160 units a year, which is really less than an hour a week. And if you're, unless you get an exception, it said the average would be 800 units. So again, are we putting in a bunch of paperwork and administration when we know these children are going to need more than an hour a week? These are our high intensity kids. We talked about questions came up about room and board. The rates cover the treatment for the residential services, but it really doesn't cover the room and board for those treatments or for those kids that need that residential treatment. Questions came up really about case management. Case management is included in this, but for kids that are in DCBS, they have a DCBS case manager, they have a PCC case manager. If they have a Sky case manager, they can get targeted case management. I mean, so there's a lot of case management opportunities for these kids, and so we don't know the need for that extra case management. And then again, with thousands of kids on the waiver, why are we limiting this to 100 children?
Hello, I just wanted to add from a provider perspective, we have been providing this service to this population really as part of a pilot since 2014, and that began with WellCare, and we work with the Department of Community-Based Services as well on this exact population, so I thought we might be able to just shed a little light on that. And our primary concerns were are already noted about the numbers that were on Michelle P. waiver, but many questions that we get at our agency are really about kids in the community, not just kids in foster care that want to access those residential services. So I think there's a far greater need for those kids that, especially teenagers that are in the community that need that residential care. Also, from our experience, high-risk behaviors demand intensive training and support. I do not think that the waiver really allows for the kinds of qualified clinicians to really get in home and do the work. When we talked about the licensed work, that is for step down and I think transitions, but not for those that are really intensively working in the home. And so I think that's where we really need to ask some questions. The length of stay is projected at 350 days. Our youth that's been in our program is the mean stay is around 3 years. We have 2 children that are about to be discharged in the next year, but they've been with us for 7 years. There is no step down for these youth. So to me, it just shines a bigger light on what is that need. And these are kids that are in foster care. And just, I was a part of that stakeholder group, and we brought up the need for providers. There are many that are on these, receiving these waiver services. Well, they're in the waiver program, but they're not able to receive the waiver services because there are not enough providers. So we're going to add another waiver, but what is the plan really to be able to develop the provider, I guess, across the state that we really need to be able to meet the need. So that's really, I think that's all I need to add.
Mr. Chairman, members of the committee, thank you for the opportunity to testify before you today regarding the new Kentucky Commonwealth Home for Improved Lives and Development Child Waiver. As a parent of a child with a rare genetic syndrome, a waiver specifically for children with IDD or severe disability is long overdue, and it's time for the state of Kentucky to take the lead on disability-related issues. As of 2023, 17.9% of our state's population have some form of disability. It was my hope that for the thousands of Kentucky children who suffer with IDD or severe disability, parents' voices were finally being heard when the news of the new child-specific waiver was introduced. My wife and I attended in-person and virtual meetings set up by the cabinet. We wanted to offer input we offered input from families on the needs of our children, input from our families on what the needs of our children look like on a daily basis, as well as the stresses and strains that this journey encompasses. These meetings seemed very positive and provided hope for families that have been on the waiting list for Michelle P. waiver for years now. It seemed that help was finally coming. Fast forward to today, this waiver has nothing to do with what was previously discussed or promoted to these families. This is a waiver seemingly designed to help children who are in state's custody, unhoused, or at risk of becoming unhoused. With the vagueness in the wording in this waiver and the stated individuals who are considered priority, I have a feeling that each of the 100 spots that are set up and for the next 5 years they're already filled. This is once again leaving the families who work every day to provide total care for their children left to fend for themselves. In the United States as a whole, as well as in the state of Kentucky, the number one reason for bankruptcy is medical debt. Every family that has a child with IDD or severe disability is at risk of being unhoused. One major medical incident may leave them so buried in debt that they can never recover. So what happens to these children when they are no longer able to receive the care that they need? Most families that were attending these meetings were no different than mine. Both parents have to work just to keep a roof over their child's head, and with that, we make too much money to receive Medicaid directly for our children. My family was blessed when our daughter got diagnosed. We were able to get approved for the Michelle P. waiver. To say that it was a godsend would be an understatement. Prior to that, the advice we received when we were struggling to keep up with our medical bills and balance a relentless schedule of appointments was to get a divorce. Then maybe your wife will qualify for benefits. I don't sit here in front of you today as a parent that needs a waiver for my child. I sit here today as a parent that can't sit back and just let this happen without the voices of my daughter, my wife, and every other family that I've had the privilege to meet and work with over the years go unheard. There's a term in politics, and it states promises made, promises kept. I feel it's time for this legislative body, as well as the Cabinet of Health and Family Services, to live up to that moniker and make it right. If this waiver proceeds as is, I suggest changing the name to describe it as what it actually is, a waiver designed for children in state's custody and foster care. Thank you for your time.
Thank you very much for your testimony. Do we have any questions of this panel? Representative Bojanowski, who was your question to be addressed to?
To the cabinet.
And I apologize, we're probably going to play a little bit of musical chairs, but thank you all three for your testimony. The cabinet reps would please come forward.
Yes, thank you. Very simple question. So at what point do you anticipate that a parent could apply for this waiver? What anticipated date?
So our implementation date that we're looking at right now is sometime in January. Oh, I'm sorry. Apologize. We're looking at an implementation date sometime in January of 2026.
Is that all you had, Representative? Okay. As far as, in the previous statements just brought up a question, will the fact that this population will be served under this waiver, will there be any net savings to the cabinet as a result of that?
The only cost savings I could think of just right off bat is that psychiatric care is very expensive. Even when we were working on the waiver, it was a lot higher than ICFID care and or nursing facility care.
And I want to also say the population that we're talking about serving through this waiver could serve children in custody, but our goal is to ensure that children do not enter state custody. So this waiver is to help to prevent that from happening. So a child does not have to be in state custody to receive, to be eligible for this waiver. And again, that's what we want to be able to, we don't want that to happen. We want this waiver to be able to serve that population to prevent out-of-home care placements, higher levels of care. So the cost savings could be by from keeping that from happening and keeping children in the community with services wrapped around them to support them, again, in their home communities and schools, et cetera.
I understand from the process of working through the DJJ Mental Health Detention Center that Medicaid covers mental health services for those juveniles that are in detention. So it wouldn't be necessary for them to be covered under the waiver. Do we have any other questions? Senator Mills.
Yes. Thank you, Mr. Chair. Just a question. Since we're thinking and heading into another budget cycle, what would be your recommendation if we were wanting to remove more children from the waiver backlog? What should the wording be in our budget document that we could be assured that you would do that? It appears to me that there was an attempt to do that, and you just took budget language and did what you wanted to do. How are we assured that we'll get that accomplished?
say we'd be happy to work on something and co-create that with you. We could have offline conversation and make sure that we can support that as well. Mm-hmm.
Any other questions? Senator Webb.
Thank you, Mr. Chairman. And this kind of follows up on what Senator Mills said. But while we're here talking about it, we're talking a lot about in-home service. But what about, and I, as an attorney, have to advise people all the time to give the child to the state. I don't like doing that. I advise against it, but you have to tell them that that's an option for them. So what about the institutional side? Are you all going to be coming with any asks regarding the institutional side? Because we've got children that aren't really accepted into any service we have. If it wasn't for Sunrise and one of my families going above and beyond over and over to the point of they can't do it anymore, what are we doing? Are y'all going to come with an ask on the institutional side regarding that population that we're having to send to other states? We're having to advise those parents to give their child to the state if they, like, say, an adoption, they've adopted this child. What are y'all going to do about that?
Well, I can speak to broadly the institutional side and then let it subset to foster care, but we've been working with Senator Carroll, and there is the proposal to think about a DJJ and a DCBS, let me rephrase that, a DJJ-specific facility that's a higher level intensity inpatient level of care, and also something that our department, the Department for Behavioral Health, Developmental, and Intellectual Disabilities, would operate. That's a no eject, no reject, we can care at a high level, hospital level of care for those kids that are just not finding placement anywhere else. So those two pieces are in the work separately. Do you want to speak to foster care more specifically?
Yeah. Senator Webb, thank you for the question. And we too do not want parents to have to give up their rights, we do not want parents to have to place children in the care of the state to receive services, which is, again, the population that we are identified through this waiver. It was used to prevent that. So to be able to provide services to families in the community, again, while the child remains with their caregivers, with their family in that setting. And if there is a need for, the waiver also does allow for some residential services as well. But again, the child would remain with their family, with their caregiver.
Well, and the preventive aspect of it is cost savings in and of itself. There's no question about that. But I just think we also have a population that we need to address that's already happening. So thank you, Mr. Chairman.
Thank you, Senator Webb. I do not see any other questions, and I know this is an issue that will probably receive more discussion. And again, it's difficult because you feel for the population, the new population, and then you feel for these parents that have been on this waiting list for years. The bottom line with it is, and it's probably the most concerning, even though I sympathize and I see it both ways, you all went against the will of the legislature, and that is not acceptable. Even though I admire the intent, and I admire that you were trying to help a population that needs help, and it's becoming commonplace that this legislature passes laws just to be ignored by the executive branch, and that has to stop. And I have the utmost respect for all three of you and what you do, and I work very closely with Secretary Friedlander. I had a conversation with him a few weeks ago. He actually came down to our part of the state and got to have dinner with him and said, Mr. Secretary, explain this to me. This is not what the legislator said. This was clearly not the intent of what we asked you to do. And then when he told me what you all were looking at, what you were doing, I wanted to be mad, but I couldn't. So it's tough, but that's there are two different issues here: what it does and how it was done. So I'm sure there will be more discussion. Anyone have anything to add before we close this out? Okay. Thank you both, or all three, commissioners, for being here. Appreciate your testimony. Appreciate your work very much.
Thank you.
Okay, the final item on the agenda has to do with the Division of Regulated Child Care. We hear a lot about child care in this committee. It's usually from the Division of Child Care. We've heard very little about regulated child care, and a lot of legislators don't understand that it is separate. And this is the aspect of child care that deals with regulations, inspections, audits at child care facilities, accountability, all those types of things. And so I thought it'd be a good idea as we move forward in trying to address the child care issue. This is a critical component as we move forward and as we try to grow services within the Commonwealth, and simply because these are issues that providers have to deal with on a daily basis. And I thought it would be, we as a body, it would be good that we got an explanation, a better understanding exactly what this division does and their relationship with the Inspector General and that aspect of child care. So I would ask that if all three of you, appreciate you being here and welcome, please introduce yourselves for the record, and you have the floor.
Thank you, Mr. Chairman. My name is Melissa Moore. I'm the Director for the Division of Regulated Child Care.
Good afternoon. I'm Andrea Day, the Director for the Division of Child Care.
Sorry. My name is Tricia Stewart, and I am the Inspector General. And before we get started, I would like to take this opportunity to thank you for allowing us to have this time to present our enforcement regulatory requirements in the Division of Regulated Child Care, so that you do have an understanding of what our processes are.
All right, so first we would talk about in our adverse action process. And our first and lowest level of enforcement, and that is civil penalties. There are two specific types of civil penalties. There are Type A violations and Type B. Type A violations are those situations which create an imminent threat or imminent danger to the health, safety, and welfare of a child. Some examples of those are failure that results in injuries to the child, including hospitalization or unfortunately death, background check issues, discipline issues that occur, falsifying records, and then operating contrary to approved services. That would be providing transportation when you were not licensed to do so. A Type B violation is when there is a concern of present that the violation could occur to the health, safety, or welfare of a child in care, but it does not create an imminent threat or danger to the child. And an example of that would be if there was a failure to respond to first aid or medical needs, or if there were staff that were present that did not have first aid or CPR training, or if a child was left alone with an underage caregiver, or if the child-to-staff ratios were below 50% or more. That would be a Type B violation. Civil penalties fall under the statute of KRS 199896, and the criteria that is used to determine the monetary penalty and assessing those of what could be levied against a child care center for a violation are the gravity and the threat of a health, safety, or welfare of children posed by the violation, the number and types of previous violations of the child care center, and the reasonable diligence exercised by the child care center in efforts to correct the violation, and the amount of assessment necessary to assure immediate continued compliance. The funds that are collected do go to an early childhood scholarship fund to help individuals who are interested in child care. And to date, in 2025, we have received $263,628.50 has been collected to that scholarship fund. Also, there are cases where penalties are trebled. That does mean that the monetary penalties are tripled and that is assessed when there are two more violations within 12 months regarding the same situation or category. Civil penalty data, and we provided that for the last 3 years. In 2023, there were 290 civil penalties issued. 242 of those were type A and 68 type B. 9 of those were trebled, meaning that they were a repeat of the violation. 2024, there was 360 civil penalties issued, with 296 type A's and 100 type B's, and 17 of those were trebled that year. And to date, to 2025, we have processed 191 civil penalties. Well, I said to date, it's actually to July 14th. The next level of adverse action is a pilot project that was started within the Office of the Inspector General, Division of Regulated Child Care, for targeted technical support. And so that is a short-term service that can be provided, and it's very time limited, about 30 days or less, is a procedure to assist providers to enact their plan of correction, and is recommended for use when there is a violation that has the potential to prompt a directed plan of correction or adverse action, but they haven't haven't reached quite that level yet. So it is voluntary, and providers we've had some providers that are interested in participating. They meet with us, with the Division of Regulated Child Care and their regional program manager in their region, to discuss those violations and receive the targeted technical support. There is an agreement that occurs, and those meetings do occur on a weekly basis, and we'll follow up for a period of the 30 days. There is training that was required for 2 hours of collaboration with either Child Care Aware, if that is a licensed facility, or the Family Child Care Network, if that is a certified home. And then at the end, towards the end of that, we do complete at least one unannounced follow-up inspection. And we have worked, this began at the beginning of this year, and to date we have had 5 different facilities to participate in targeted technical support. A directed plan of correction is the next level of action that occurs, and that is based in the regulations 922 KR 2090. And it covers situations that the cabinet may determine that a violation warrants a directed plan of correction. So if there's violations or if there's citations that occur from a survey, a facility completes a plan of correction, if they reach a level of concern, we assist them in creating a directed plan of correction. And in this case, the division regulator will meet with the provider and enter into that agreement. The agreement details what must be done to remedy the violation and achieve compliance. So some of the parts of a directed plan of corrections: parents of the guardian or child, if there was an incident they were involved, they are made aware of the situation and that what has prompted the directed plan of correction, they must be notified that that has occurred. And then we monitor more frequently the center during that time that the directed plan of correction is in place. And the provider staff may be required to participate in additional training. There are 3 additional training hours that are required by all staff. And additional training can be required from that, like per se, let's say first aid or CPR was needed. Would be an example. And the agreement may be amended if additional violations are identified during the directed plan of correction monitoring. The most common violations that lead to a directed plan of correction are abandonment or elopement in supervision, and individuals left alone with children left alone with individuals without background checks, and then severe violations of health, safety, and comfort. Directed plan of corrections require at least 3 successful monitoring visits happen before we can lift the directed plan of correction. And a directed plan of correction will be implemented if we issue an emergency suspension of the license. It always follows next. And then directed plans of corrections may be utilized in cases wherein staff or person is under investigation as an alleged perpetrator, and that if that was an ongoing investigation. The next thing we have in our adverse action process is a denial. A denial is of a license or certification can be used under the following conditions, or is generally related to other types of adverse actions. For example, an application is received from an applicant who has a previous ownership interest in a child care program that has had a prior certification, license, or registration denied, revoked, or voluntarily relinquished as a result of the investigation or pending adverse action, and 7 years has not passed. So there has to be 7 years that passes once a revocation has occurred before a person can reapply. And to date, for the last 3 years, the data on denials, in 23, we did 2, 2024, 1, and this year we have done 3 so far. Our emergency suspensions, regulations, and statutes are based in 922 KR 2010 and KRS 19896. And in there you can find of course, the conditions in which emergency suspensions are necessary. And again, it is a regulatory violation primarily that is found to pose an immediate threat to the health, safety, and welfare of children in care. Emergency suspensions are intended to be a temporary process that results in immediate closure of a child care facility. A suspension may be lifted and an acceptable plan of correction be issued, once an acceptable plan of correction is received, and a directed plan of correction would be issued upon that receipt. Providers may not operate while that suspension is in effect. And when the plan of correction is received, as I said before, we will continue to do ongoing monitoring until we have 3 successful visits through the directed plan of correction process. Some of the common reasons for emergency suspensions are inadequate supervision, background checks or insufficient background checks to have qualified staff, and then providing unapproved services or operating in an unapproved space. If the space is not licensed and they were actually operating in an additional building or something of that nature. And then conditions that cause harm to children would be inappropriate discipline or actions that cause a significant injury. Last, we have revocations. This is the most significant action we can take against a license because it is a permanent, if approved, it is a permanent action for closure. And so providers may continue to operate through the appeal of a revocation. Some issues that might lead to revocation, in addition to directed plans of corrections and emergency suspension examples, are if the provider interferes with the cabinet's ability to perform on an official duty, or a parent is denied access to the child care center during hours of operation, the licensee is discontinued or disqualified from the child care assistance program or another program due to fraud, abuse, or criminal conviction, and then failure to meet a requirement of a directed plan of correction, and then providers knowingly misrepresent or submit false information on a form by the cabinet, or more than 2 directed plans of corrections in a 3-year process, or last, failure to pay civil penalties. There are appeal options if we are required to take an action, and those occur for civil penalties, emergency suspensions, denials, and revocations. They all have the right to appeal. That begins with an informal dispute resolution conference that is provided by the Division of Regulated Child Care, and that it would be with a regional program manager outside of the region of the occurrence. And the provider has the opportunity to dispute that violation that prompted that action. A determination is made from that IDR, or that informal dispute resolution, and they do receive notice of that. If it affirms the action, they then have the opportunity to move forward with requesting an administrative hearing. Administrative hearings, providers may request that appeal with the hearing officer, and it does require legal representation be present. If that if the administrative hearing also does not overturn the decision, they can appeal that last to circuit court in the county in which the event occurred. All adverse actions are the status showing the directed plan of correction, emergency suspension, and revocations. All of those appear on the public portal. So anyone that wants to access that portal can identify that their child care center or their certified home that they are utilizing has received one of these actions. And a provider may have multiple actions against the license or certification at one time, depending on the severity of the violation. So an example is a severe supervision incident may result in both an emergency suspension for the immediate closure of the child care center or family child care home, but then also a revocation because the action meets the requirement per regulations for revocation as well. The provider could reopen if the emergency suspension were lifted and continue to operate until the revocation appeal process is complete. And we have some data about our adverse actions. In 2023, we processed 10 revocations, 2 denials, and 10 emergency suspensions. In 2024, it was 5 revocations, 1 denial, and 8 emergency suspensions. And so far, up until the 14th of July, we have processed 10 revocations, 3 denials, and 7 emergency suspensions thus far this year. As you can see, we have some information of the data breakdown in the beginning of 2023. Some of those, probably the greatest violation that occurs for us, as you see here, are supervision. That is across the board. You can see in 4 cases the revocation, that was the primary issue, also for a certified home, and then for emergency suspensions as well. And so those 4 could have most likely be tied in together, that the actions would have been taken at the same time. The next would be health, safety, and comfort for a child. You can see there is the most significant cause. And then again in 2024, the breakdown is supervision was also the biggest, and health, safety, and comfort were the largest areas of concern for revocations, with one in a certified home being over capacity. And then for the emergency suspensions, it was supervision, health, safety, and comfort, and then total capacity as well. And for 2025, so far we have not taken or had any actions for a certified home, but for the revocations that have taken place, supervision has been the primary issue with health, safety, and comfort. And also we had, in this particular case, cooperation with the Cabinet for Health and Family Services Agency. And then for emergency suspensions, it was also supervision, health, safety, and comfort as well. And then background checks is often an issue that is of grave concern.
So the Division of Child Care, we are required under the Child Care Development Block Grant to provide consumer education to parents and the public. And posting of the total number of serious injuries, deaths, and instances of substantiated abuse in a CCDF eligible child care provider setting, we're required to do that. And we were not in compliance with that for a number of years, and now we are. If you'll move to the next slide, this will show the historical data that also shows our total license capacity in each provider type, as well as the number of serious injuries reported, the number of deaths over the last 3 years. And then the total instances of substantiated child abuse or neglect. This was how many substantiations were made by the Department for Community-Based Services. So the Child Welfare Agency did substantiate abuse or neglect in these instances, which is separate from what DRCC investigates.
That concludes our presentation, Mr. Chairman.
Senator Webb, start with you.
Thank you, Mr. Chairman. I just have a couple questions. I'm pretty familiar with the way this works. I've represented and advised workers from everything administratively to criminal on this, and sometimes it doesn't, the allegations really don't amount to much. But we want to get rid of the bad actors, and we appreciate that part of what you do. Could you tell the committee where your cases originate, like who brings them, how you get them outside of your regular inspections?
We have several forms of receipt of ways that those are processed and received. We start with the licensed and certified programs are required to self-report is first. Then we receive reports from parents. Often we receive reports from employees of a child care center or a certified home. And then also there is a crossover from DCBS.
So caseworkers or staff in those local offices can also be the origination of the report?
Yes, ma'am.
Who conducts investigations when a caseworker brings it?
So it's in twofold. DCBS would investigate the actual abuse or neglect. We, within the Division of Regulated Child Care, investigate the regulatory violation for a licensed or certified program.
So you all work together or have interaction on that? Both processes go along at the same time, or how does that go?
That is correct. Sometimes a DCBS investigation through their appeals may take longer than what it would take for us to complete an investigation, but we do those in tandem whenever possible.
And are your caseworkers in DCBS, are they trained specifically for that type of regulatory, or do they just do the normal abuse and neglect standards?
No, our staff are trained specifically for regulatory violations rather than identifying abuse and neglect.
And if I may, I think to get to the heart of your question is, yes, you have DCBS that's mandated to investigate those things that meet the statutory definition of abuse and neglect, whereas DRCC, while that is, if they see that, they have to report it, but they are looking much more in depth at what the federal regulations and state regulations require for these entities. So while there is overlap, each has a very different scope of work, if you will, but they do overlap and they do complete joint investigations.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator. Representative Callaway.
Thank you, Chairman. It was a great presentation. Thank you over here. Yeah. I just have a quick question, just curiosity. So the violations, type A and type B, I see type A is up to $1,000 per occurrence. How are those figures established for each of those?
It is determined by whether or not they have had any previous penalties, also the events, the time. We look at factors that play into that. Like, for example, if it was an issue of supervision, was the child left alone for a significant amount of time? If the child was outside of the facility, if the child has some behavioral issues that make the child more at risk, that they struggle to understand, or if they're, for example, if there was a lake or something near there, that does increase the severity, and so that does move that in that sliding scale of determination. Those are the things that we do consider.
A quick follow-up. So there's no set fee for an offense?
It starts with a basis of $950, and then there are some reductions, but it can be up to $1,000. Yes.
And that's determined by your?
That is, we have a civil penalties coordinator that makes that determination.
Thank you.
Thank you.
I'm going to make a couple comments and ask a quick question, then I'll have more later. And I want to be completely transparent before I make these comments. You all know that in my private life, I was the CEO of Easter Seals West Kentucky. I am retired, so I had no connection with that organization at all. However, before I take that back, my daughter still attends. Before I left, and in 15 years there, 14 3/4 years, never had any interactions with the Division of Regulated Child Care other than maybe a citation. Before I left, I got a huge taste of dealing with the Division of Regulated Child Care. I had concerns both as a head of an agency and as a legislator about what I saw, what we went through with this, and it was a little concerning. And so, with that being said, in laying the groundwork for this, you all will understand where these questions are coming from. My first question, and this comes from talking to providers all over this state. We are seeing the incidence of severe behaviors, violent behaviors in child care more than ever before. What is the Division of Regulated Child Care doing to address this, to assist providers other than holding them accountable for the results of these behaviors? And have you all seen this? Do you all talk about it? What's your thoughts on that area?
Thank you for asking that question, Mr. Chairman. It is a grave concern for us. It is the reason why we created the targeted technical support option, because we are seeing an increase in the behavior for children and realize that providers can use additional assistance. There are 2 programs that are available for them. They're for licensed programs. There is the Child Care Aware. It is a free program that provides training and works very closely. They will work through the adverse action process if that occurs. And for certified homes, we have the Family Child Care Network. But the Office of the Inspector General in particular identified the concerns that you're speaking of. And as a result, we initiated the targeted technical support so that providers could, before reaching the level, if we had identified early on in some deficiencies that were issued and plans of corrections that a center was struggling and that there may be the potential that they were having some children with some exceptional behaviors or some staffing issues or things like that, that we could step in and provide technical support for them as the regulatory agency to help them to overcome these barriers and to be successful to stop that and actually to achieve the plan of correction in hopes of preventing any additional adverse actions from occurring.
Okay. And I've heard it from several providers that consistency is a problem. And normally when you have a progressive discipline system, so to say, you know what to expect. And I found through the process that I really had no idea what to expect, which leads to the reason that I called you and asked you to come to Paducah to meet with our staff to help a center that was in crisis. Have you all talked? Have you met with your staff across the state about, and this may be more under the inspectors with the OIG, about being more consistent about results and accountability from provider to provider?
We do meet with, I'm sorry.
No, go ahead if you want to.
I do meet with our regional program managers. Actually, we meet weekly to discuss these issues and concerns. And one of the reasons I'm not able to visit in particular centers is if I did make a visit to a center and there were some violations that I saw, as a representative of the Office of the Inspector General, I would be required to cite those. And so you can imagine that it would be a very difficult situation if I'm there to be in a role of support and then also required to cite an issue. So as the director, I often will meet with centers if requested and provide the support that they need to help through those processes. We do those on Teams calls, phone calls, and we can meet within the Cabinet for Health and Family Services. It is just not the best option for us to meet at the actual facility due to the requirement to cite any additional violations. But it is our effort to be consistent. We do meet regionally with every manager and coming together to discuss those. And we have a process by which we review those adverse actions to make sure that we are trying to be consistent. However, there are a lot of variations to those that play in that. And of course, because it is a confidential matter, not all centers recognize and know what the reasons were that impacted one center from having an emergency suspension and another center from having a revocation. And of course, we would not discuss that due to confidentiality.
And I'd like to say it's important to remember that we are the regulated, we're the oversight agency implementing or ensuring that facilities are in compliance with the regulatory requirements. And there are programs, and I believe the Division of Child Care has programs, coaches. So in the scenario that just a hypothetical scenario like you just mentioned, that would be something that more probably would be referred over to the Division of Child Care in DCBS.
And if I may, I want to take a moment to recognize the consistency issue. That is something, we've heard that as well. Something that the Division of Regulated Child Care has started doing is a program that they call One Team, One Mission, so that they are coming together on a more consistent basis to talk about those things, because you're right, an answer should be an answer whether you're in Pikeville or Paducah. There should be that consistency. So that is something that we've heard that feedback. We work as a team, as OIG Stewart mentioned. We do contract with Child Care Aware of Kentucky for health and safety coaching, training, professional development, and quality. We also have a monthly meeting with most of our stakeholders as far as the Child Care Health Consultation Group, Early Childhood Mental Health Specialist, TRIS, OIG, our cabinet, to talk about these are, I'm sorry?
Public health.
Public health. These are some things that we're seeing. How can we address those consistently? And that way that we're a more unified front. I think we've been trying very hard in the past few years to do that. We're slowly getting better, which is the whole point. And to bring another issue up, what is a citation? What gets cited the most? That's something that we've talked about as a team, to start looking at that monthly and then sending out information to providers about, this is what we see as an issue. Here's a tool for that. That way they're not scrambling thinking, how do I address this? But being more proactive and giving them that support, because we do hear that. And we do hear about the challenging behaviors. And that is something with professional development that we'll continue to explore.
Okay. Senator Mills?
I'm good.
Okay. Representative Doan?
Thank you, Mr. Chairman. I have a constituent in my district who operates a martial arts dojo, and he, along with a number of other operators around the state, received letters that they were going to be regulated as licensed child care centers. This was in 2024. We passed a bill, House Bill 491, to address that issue. Subsequently, there was, I believe, litigation related to this. The enforcement continued on throughout the state. My question is whether there's still any pending litigation regarding these issues, and whether martial arts facilities are still being treated as child care facilities.
So I'm not able to speak to the legal ramification or where that is at this time. What I can say to you is that if we receive information that often, well, let me say this, often we receive contact information. People will reach out to us to alert us to what they believe is a facility that's providing child care. So one of the things we do is we investigate whether or not facilities meet the criteria based in the statute to determine child care is being provided. At the time, I believe martial arts, sometimes martial arts programs, sometimes summer programs, different organizations will meet that criteria. And of course, there is that exemption that was passed. I believe the litigation that was started from that was before that was passed. So other than that, I'm not sure if it's still pending. I do believe it is still pending, but that is all the information that I know.
Thank you. One of the main issues that I struggled with, and this has been over a few years, is you could have a provider who 5-star rating reports every incident that occurs, yet no matter to what extent, and you all do a great job at training, and there are resources there. I don't question that at all, and I know providers are very much appreciative of those resources and all that is done. Despite everyone's efforts, no matter what we do, what child care providers do, there are going to be incidents where staff do things that are not consistent with protocol, with policy, with practice. Oftentimes it is related to severe behaviors. I can tell you before I left, my parting action was to send out a memo to our families that we had a 2-strike policy from that point. On the second strike of any behavior that could lead to an incident that we would have to report, we no longer provided services. I had to let more kids go within a 2-week period than I had in the previous 15 years. That's what I had to do to keep our doors open. So with that being said, we have staff, all providers have staff to do the training, you have the resources. When you get put in a situation when you've got kids with major behavioral issues, from time to time, staff are going to react improperly. And the problem is that the vicarious liability, you could have a great center who does everything right. You could get a few staff members over a period of a couple years that are in that situation that gets reported. There could be a citation, there could be a civil penalty, and you could end up closing your doors pretty quickly. I struggle with that. Have you all considered maybe separating some liability from the staff themselves and the center, and maybe focus a little bit more on training and on accountability for staff members as we move forward? And because basically, you're penalizing some providers who go above and beyond to do the right thing. You're penalizing them for actions of staff that they couldn't have prevented.
Mr. Chairman, I would say that weighs very heavily the same for us as the Division of Regulated Child Care. It is something that we do consider, and we work to try to work in partnership with all of the different organizations and agencies that you spoke of to try to put as much education out there as possible. What I can say, though, is that one of the things that is in place is the emergency suspension, which is really while it does immediately close a facility, there are no additional penalties for that for a center. And so it is often a restart in a way for while it has a significant impact, it does allow for us to have an opportunity to work with that provider to move forward, be that if there needs to be new staffing, additional training, additional partnership. So yes, it is something that weighs heavily for us, but in the end, the health, safety, and comfort of children is what is paramount. And for us as a division, we are tasked with ensuring the regulatory minimum standard requirements for child care facilities.
Okay. Would you oppose legislation that separated the liability and put in the ability to separate the provider from the offender?
I would welcome the opportunity to have those discussions.
Okay, thank you. The final comment that I have has to do with the appeals process. I think the appeals process is set up to discourage providers from appealing. You go through the informal process, and that's very simple, done over a phone call, and you get a decision. But then if you've been given a civil penalty, and I think the max is around $1,000 if I'm not mistaken, if you go into that second formal appeal, you're going to spend more than what the civil penalty is to pay an attorney to represent you. I would love to see some changes in that. I think that's unfair that process is set up that way, and it it's going to cost a center more money to appeal it than it would be to pay the penalty. So I struggle with that. And a final comment, everybody knows that we're suffering for child care providers in this state, and there's a concerted effort to grow child care for many different reasons: workforce, early childhood education, educational attainment beyond early childhood education, many factors. I feel like this system is set up to discourage the growth of centers and centers opening their doors. And I think there needs to be a little more standardization in the way this is established. And again, I compliment the training and the resources that you have. The process, it scared me. And I'm not saying this because I was the CEO. I say this on behalf of a vice president and a staff who worked their tails off to do the right thing. And we dismiss child after child after child because of behavioral issues that we shouldn't have to dismiss. We should be addressing care of those kids, but it's not there. And when I see the staff there from day to day, are we going to have a job tomorrow? When I see parents that walk by, are you all going to be open tomorrow? When I see a 5-star center get hammered by the media for something that we as a center couldn't control, and I know that our center was not the only one that went through that, that troubles me. And if I'm someone that sees all of that and I'm thinking about opening a child care center, not going to do it. So I agree with accountability 100%, but I think the system is flawed, and I think it needs to be reviewed and it needs to be standardized. The staff that came on site with the OSG's office, I can't say enough good about those ladies. They were wonderful. But I really struggle with this as we move forward trying to grow child care. And we'll have some legislation this next session to start us down that path, and hopefully we can get some things move forward to help in that area. This is a critical component of that. And there can't be an adversarial relationship between you all and providers. You've all got to be on the same page. Providers are facing hardships that they didn't face in the past with the behaviors. I spent about the last 2 months of my career back at our child care center because I wanted to see day to day what was going on. I felt sorry for those folks, the things that they had to put up with, getting punched, getting hit, getting spit on, getting cussed at. And that was a daily thing for some of our classes, and staff after staff leaving. And I know this is common throughout the entire state. Providers have told me that. So I think we need to look at this a little bit closer. We need to look at the relationship. We need to look at the structures. It's all part of a bigger picture. Like you all said, we all have to work together on that. But you all forgive me for making this personal, but I'm retired now and I can say things that I couldn't say before. And it's important, and it's important that you all hear from someone who's actually been through this. I had providers over the years that have come to me complaining. I'm like, there's nothing wrong with that system. It works fine. I don't have any issues with it. I can't say that anymore. And so I feel like we have some work to do, and I hope we can. I hope you all will help as we maybe propose some legislation that will help in this area, maintaining accountability, but maybe being a little bit more understanding to the current situation and maybe putting responsibility where it belongs. And I will get off my soapbox and stop. Does anyone else have any questions? And I sincerely apologize for monopolizing this conversation, but it was fresh on my mind. And I just don't think we've had this conversation before regarding this division. Senator Webb.
I feel your pain. I live in a child care desert with new providers that are good providers, and they're facing some challenges right now. But I would just say providers got to protect their interests, and Representative Doan might agree with me. If you get your lawyer engaged in the beginning, don't talk. I advise my clients, don't talk to the cabinet unless I'm there. Don't talk to the enforcement unless I'm there. And so that preventive legal payment up front will sometimes help you from having that appeal.
And the problem that providers have a lot of time is if you have insurance, your insurance company will dictate what attorney you get. And, there are a lot of things that they dictate through that process. if you use the insurance policy. But it was just an eye-opening experience and a very scary and troubling experience, not knowing from day to day if you all were going to show up and close our center down, 120-something kids without services. For our community, that would have been devastating. And not really being able to get a clear answer because there was still an incident pending. Are y'all going to be back any day and pull our license from here on out? And it killed me, one, to watch our families, to watch the kids that had to be removed from the center, and to watch our staff, and nothing I could do. And that was just unsettling. And as a legislator, I don't want to see other folks go through that. And I think we have some work to do on that as part of the overall problem. When is our next meeting? The next meeting will be Wednesday, August the 27th at 1 p.m. Thank you all for being here, and thank you for the discussion. And despite all of my soapbox talk, I do appreciate what you do. And I know you are concerned about the same things that we are. We got to get some things done in a lot of different areas of early childhood education. Ladies and gentlemen, we stand adjourned. Thank you.